Bismillahirrahmanirrahim. I am Dr. Rashka Hina. I am working as a Senior Registrar Gastroenterology at Gangaram Hospital, Lahore. Today we will be discussing about chronic idiopathic constipation. This disease is often remain untreated, but it has a huge impact on the quality of lifestyle. To discuss this, we have with us Professor Zahid Azam. He is the professor and director of National Institute of Liver and GI Diseases, Dow Medical University, Karachi. Thank you so much, sir, for giving us your precious time. It is really an honor to share this platform with you. So to begin with, I would really like to ask, in your practice, how often you are seeing the patients coming with the history of idiopathic constipation?
Basically, we are seeing a lot of patients and they are mixed sometime with a condition called IBS-C, irritable bowel syndrome, constipation dominant irritable bowel syndrome, and sometimes they are CIC, and you have to differentiate between the two. So like in a practice of gastroenterology, any gastroenterologist is seeing majority of the time like 15 to 20% of the patients who are suffering from chronic constipation, be it CIC, be it IBS-C.
So I will come on the IBS later. I would really like to ask, what is the burden of CIC, especially in our region like Asia, and is this any difference between this burden here and you in the West? Is there any difference of this disease?
CIC basically is here as well as in the West. There is a difference that their diet is very low in terms of taking roughage. Fiber is lacking in their diet, and that's why they have more CIC as compared to we have in our country, because of our staple diet is wheat, and that contains a lot of fiber, and hence there is a difference between West and East.
So you have mentioned IBS, that a lot of patients come with IBS-C. So what is the particular criteria in which we can differentiate between IBS-C and chronic idiopathic constipation, that is CIC?
So basically the differentiation feature of the criteria that we use is Rome 4 criteria for diagnosing IBS, be it IBS constipation dominant or diarrhea dominant, or the mixed feature which is overlapping with constipation and diarrhea. The differentiation between IBS-C and CIC is basically the difference is abdominal pain. So when we are dealing with CIC, it has nothing to do with your abdominal pain. If you have abdominal pain and falling into criteria of Rome criteria, then we say that this is IBS-C. Whether if this is associated without pain and severe constipation, then this is chronic idiopathic constipation or CIC.
So like you have said, a lot of patients and a majority of patients coming with this CIC. So what will be the first line of investigations, like the basic test to do in the CIC?
So you should start with a good history. If they are suffering from some time with chronic constipation, and there should be no red flag. If you have red flag, then you need further investigation, and you need to refer them to a proper gastroenterologist who is going to run further tests, including maybe colonoscopy. So the red flag being unexplained weight loss or unintentional weight loss that we can say. Other thing is the bleeding in the stool, or this could be new onset constipation. So these are the red flag. Then a family history, of significant family history in the family for colorectal carcinoma. That also, so first you need to run some tests like run CBC, run TSH at least, because you have to exclude that they are not suffering from hypothyroidism. You have to exclude that at least run stool DR, that there is no blood in the stool, microscopic blood, or at least do 3 sets of stool occult blood, so that if that is negative, TSH is normal, CBC is normal, then you can say with a background history, typical history of constipation, that the patient is suffering from CIC.
Right, very right, sir. But sir, I'm sure you have read the ACG guidelines. They recommend about anorectal manometry. But in our setup, like in Pakistan, we don't have many setups who are doing the anorectal manometry.
So anorectal manometry is available in big cities like Karachi, Rawalpindi, and Lahore, and some maybe Islamabad.
But in very few hospitals.
in very few tertiary care hospitals, which are center of excellence in GI.
Exactly.
So that's available in our center. That's available at Lahore, Islamabad. So that's not available. Expulsion, balloon expulsion test is the standard test that we do. But I will tell you, as a physician, all physicians who are dealing with a person having constipation, at least they should do digital rectal examination. Ask the patient when the finger is inside the anal canal, ask them to squeeze. So that is a digital rectal examination with the squeezing test is going to tell you the tone of the anal canal, and that is also called Pursman manometry. That is going to tell you a lot of information, like if Khuda na khasta there is a mass or any lesion or polyp that can be palpated with your digital rectal examination, and then the squeeze that they have enough pressure that they are generating.
So, sir, like our burden is like huge burden, but our setups are very few to diagnose, like the fancy tests like anorectal manometry. So
don't go for fancy test, just rectal exam, good history, and exclude few things by running very cheap test.
So, what message we are giving that anorectal manometry is not very essential, or it is not creating the huge impact, especially on the management of the constipation?
Yes, it comes in the management of constipation, but every person doesn't need manometric test because we are dealing with a condition which is very common that comes to every day, and our family physician and GPs are encountering this disease. There is a few chunk, like 15-10% of the whole population that's suffering from CIC comes to gastroenterologist, and among them, very few needs manometry. If you are not getting better with your initial treatment, then you may need manometry.
Right. So we have been seeing patients like there is a general concept that old age patients come with the constipation because of their decrease in diet, but nowadays we are seeing that very young patients, especially like the teenage groups, they are coming with the constipation. So do you really think this is the diet, that the junk food that is adding or aggravating or
this is all because we need to have, if you are suffering from constipation, we need to tell our patient that you need to increase your fiber intake, you need to increase liquid intake. And what you are saying in our younger population, when we are seeing constipation, severe constipation, this is because of processed diet that we are consuming nowadays.
A lot of carbs.
A lot of carbs and processed food and less fiber intake. So that is the problem. So whenever your patient is coming to you with severe constipation, tell them to have a lot of fiber and fluid intake, be it plain water, tea, coffee, or juices. The other thing is increase fiber. So they should not take the fine atta, flour, fine flour, and they should be whole grain wheat. Then they should have salads or raw vegetable that has fiber, cucumbers and other things are the example. So they should have some, if their patient is suffering from severe constipation, tell them that they should have some salads while they are having their lunch and dinner, increase water intake. And in elderly, sometimes we do see a lot of constipation, and that is because of decreased mobility.
Exactly.
They are bedbound, or they are most of the time sitting at home. They are not mobile. So mobility also increases your bowel movements. So that is the first step that you need to initiate among them, and then we talk about medicine.
So you have very well explained about the diet. I would really like to ask that what is the role of ispaghol husk? It increases fiber in your diet. So what is the right way to take the ispaghol? Some said you can dip it in the warm milk. Some are taking it dry and then drinking the water. So what would be the right way that we will?
So ispaghol can be used for diarrhea as well as constipation.
Exactly.
So when you have constipation, so the ideal way is take a big jar or the container where you can use 2 tablespoons and soak it in a full glass of water for 15-20 minutes, it's become jelly-like. And then you should have that at bedtime, so that you have a good bowel movement in the morning. And this is like, it becomes thick. So there is some residual that remains sticking in your container. So pour another glass of water in that and then have it. So that it gets you fiber as well as water. And then it forms a bulk. So it increases the bulk of the stool so that you don't have to strain.
Then, sir, coming to the management, we have discussed the lifestyle changes and dietary modifications. Now, we would really like to discuss about some of the therapies that are available, like the new drug, prucalopride, is now available in Pakistan. So, what are your thoughts about this drug?
So, first thing is always measures like increasing fiber diet, water intake, increased mobility. If that's not working, you may use medicine like 5-HT receptors, prucalopride, which is a prokinetic medicine, because cisapride was the blockbuster drug that was quite many years ago, and that was withdrawn because of cardiac side effect. It increases the QT interval, and now this is the major breakthrough that this drug is available, and this is freely available in Pakistan market as well.
Exactly.
With an affordable cost as well.
So, sir, do you think everyone should be taking it right from the start away?
Ideally, they should have initial measures. You can use psyllium or husk. If that is not working, we can use polyethylene glycol substances.
Exactly.
If that is not working, then prucalopride.
Sir, what do you think what will be long-term side effects of this prucalopride in our?
The experience is not much, like 10-15 years, but whatever the experience is available in terms of trial as well as post-marketing studies, this is relatively very safe drug. So hopefully that can be taken long-term. You need to tell your patient that they need to titrate according to the bowel movements that they should take. This is not always. Sometimes patients come to us that now, previously they were having constipation and now they are having diarrhea. So they need to stop, because you need to tell them how to use it. So this is a PRN or SOS, what we call, as and when required basis. So if you have severe constipation, first measures are not working, introduce this medicine and then use it accordingly and titrate. If you have bowel movement, don't take it.
Sir, in the management, biofeedback therapy is also very important, but unfortunately, we are not been telling this to our patients.
And the reason is that is not available.
Exactly.
Biofeedback is a very good tool to teach your patient how to evacuate. Other thing that I would tell you right now is how to defecate. Unfortunately, the people are, as far as the Indian commode is concerned, you have a squatting position where you evacuate and move your bowel movement. So you exert your pressure exert pressure with your lower limb against the abdominal wall or your belly, and you evacuate your bowel. When you are sitting on English commode, that is not happening. So if you are using English commode, the other thing, the first measure is take a stool and put your steps on that stool so that your legs are flexed and that exert pressure on the abdominal wall and your belly, and that's how you can exert more pressure along. And then if that's not working, yes, biofeedback mechanism is helpful, but unfortunately that's not available. As far as I know, that's not available in the country.
So one last question. What will be your message to the younger doctors like GPs and PGs, that when they should refer the patient to a specialist, especially if there is a history of constipation, and they should know, they should stop it and refer straight away?
Okay, one thing is very important. You should not miss red flags. Red flags, low hemoglobin, then you need to refer for colonoscopy, unexplained or unintentional weight loss, family history of colorectal carcinoma, and any new onset constipation. And sometime if your constipation is not getting better with your measures, then you need to refer. And the other thing is for bleeding, please, it's my message, sometime, majority of the time when you have bleeding PR, in our country, as TB is very common, people start TB therapy or ulcerative colitis therapy. Don't start therapy until you have the scope done.
Thank you very much, sir, for your precious time. And I would also like to thank Frozen's Laboratory for arranging this platform where we can educate among ourselves and each others. Thank you.